So robotic surgery or minimal invasive surgery was really something that caught my attention very early on during my training. I saw it as a way of not only minimizing the amount of tissue disruption that we do, but I was confident very early on that we could actually improve patient outcomes using this technology. I went through a journey that is not a typical journey in my training. I'm originally a foreign medical graduate, did some of my training in Egypt, then moved over to Europe where I was introduced at that time, not robotic, but laparoscopic surgery. And there were two key people in my career at that point that influenced really my decision to say that this is the way forward. Claude Abou in France, Paris, France, where I trained with, and Günther Janicek in Austria at that time were two people that really made me believe this was the way to go. After really mastering that technique during my training, I was faced with a decision whether is this enough, or do I continue and do further training in robotic surgery in the United States? At that time, it was really becoming very prolific. And my mentor, Dr. Janicek, told me something. You are at the precipice of when robotic technology is going to take over. Although you're very good at what you're doing, I do believe that this technology is going to become the next wave for urologic surgery. And so I, bit the bullet, spent another 2 years in the United States at the University of Rochester training in robotic surgery, and then stayed on as staff for another 10 years, and then moved to Johns Hopkins, or the Brady Urological Institute at Johns Hopkins, where now I am director of robotic and minimally invasive surgery.
So you are now a mentor to many, and that's important,
yes,
isn't it?
Of course. Yes. Mentorship is a very big thing in surgery. And mentorship doesn't mean just teaching somebody how to do surgery. Mentorship is really developing a surgeon, because a surgeon is not only somebody that performs surgery, but somebody that makes informed decisions, somebody that has the capacity of judging and dealing with issues in the operating room that come up that are unexpected, but also somebody that is able to teach future generations. So when we talk about state-of-art simulation, we need to define what that means. What is our ideal simulator? The ideal simulator is one that is realistic, both anatomically and texturally. I usually tell my trainees, I teach you so that you can teach the next person. It's something that we continue to hand down, and this is really looking into the history of Johns Hopkins, where the first surgical residency ever started, and William Halstead started the whole revolution of organized training. And what they used to do was have mentorships or have apprenticeships where they used to teach, and then further people used to teach. And there's a huge saying that we have where if you come to every surgeon that got taught by a surgeon and a surgeon and a surgeon, it all drills down to some of the pioneers at Johns Hopkins.
So what are you most excited about now in the future? What do you
Well,
foresee?
two main things, right? So first, my passion is really in education and training. And I have seen that change tremendously from being something where we used to, sit down in these old dusted basements in hospitals where we used to try to practice on different types of makeshift models that all of us were very creative in using. I remember my first one was basically a sponge and learning to separate the yellow from the green, and that's a dissection task with laparoscopy. And at that time, I was using a small webcam, and these were all makeshift models, and we knew that there was a way that we needed to learn. Look at how we are training now. We are not only so sophisticated in the fact that we have 3D printing, hydrogel molding, which my lab specifically works on, but there's a lot of virtual reality, augmented reality, and insights that trainees are capable now of recreating almost a very realistic operative experience with all the errors and all the emergency situations. But take that a step further. There are dedicated centers for training and learning now with specialists that have degrees in learning and training. I myself have a master's in education, but fueled with the theory of learning, along with the technology that's been involved in learning right now, is become a fundamental factor that has really revolutionized the way that we do robotic surgery. The second thing is, we're not done. There is further miniaturization that is happening to these robotic platforms, regardless of who's making them. But we're getting smaller and smaller and smaller. And not only that, I think this incision is small enough, we can't make it smaller. But what we're trying to do is we're trying to regionalize and compartmentalize surgery. If you want to get to the target organ, you have to clear out a bit of tissue to get there. We are limiting the amount of clearance of unnecessary tissue, and we are truly regionalizing surgery once again. So there is a huge potential for us to be able to further miniaturize surgery, but also including technology into that and improved visualization gives us insight into what is behind the tissue, what is hidden behind the veil, so that we know where we're going. And very soon, we are going to do very, very minute interactions with the tissue to get to the target organ, opposed to what we do now, which was like to, they usually say surgeons have to expose, widely expose in order to be able to get to their target organ. That is the way of open surgery. We have now tended to minimize all that because we have enhanced visualization and enhanced software that has the capacity to have us look behind the tissue, what is hidden behind the tissue, and so attack only the area that we need. The Vattikuti Foundation has a huge history in robotic surgery. I truly believe, had it not been for that initial push to have robotic surgery introduced in urology, we would have still been doing it the old way. And robotic surgery might have not launched, or another specialty might have picked up, because it is a very inspiring and very revolutionary technology. But in any hospital, whether it's United States or Europe or India or any place in the world, urologists are at the top of robotic surgery. And it's because of that initial push and the Vattikuti Institute that started it all. We have to say that we trace back all of our innovations in robotic right there. And now they've allowed other institutions to innovate and other places to innovate. They've gone beyond just helping people do robotic surgery to helping people learn how to do robotic surgery. And there's even more and more. So, I would say it is an incredible effort that is persistent for over 20 years now and is still pushing the envelope in having us be able to do more and more with this technology.